The broadcast is now starting. All attendees are in listen-only mode.
Hi, everybody. I wanted to welcome everybody to this first of a series of webinars on depression. I'm Kate Sarenholt. I'm the Executive Director of NAMI Maryland. That's the National Alliance on Mental Illness. We are one of many state NAMI organizations that are part of the NAMI Alliance, and we have a number of local affiliates in Maryland. I am really here to thank Dan Hale and his crew, as well as our wonderful staff, for making this happen. It's a great opportunity, and as with all of our webinars and other resources, it will be recorded and it will be posted for people to observe. Thank you very much for attending, and thank you, Mackenzie, Maria, other NAMI Maryland staff, and especially Dr. Dan Hale, who's been a great NAMI partner. Thank you.
Hello, everyone, and thank you for joining us. My name is Mackenzie, and I am the Community and Provider Education Coordinator here at NAMI Maryland. I will be the moderator for our webinar today, along with my colleagues Maria and Samantha. Depression is now recognized as one of the most serious health concerns. Each year, more than 10% of American adults experience a major depressive episode, and more than 20% will experience at least one episode over their lifetime. Furthermore, we know that depression is the major risk for suicide, now the second leading cause of death in the 10 to 34-year-old range, and a fourth leading cause of death among adults ages 35 to 54. We also know that depression is a significant risk factor for substance abuse. Today's webinar is supported by the William S. Perper Foundation, and we are hosting a special guest, Dr. Dan Hale, who will draw on his own struggles with depression, his work as a psychotherapist, and his experiences as a father who lost a daughter to depression, to offer guidance for individuals and families impacted by depression.
Before we get started, we wanted to note just a few housekeeping points. To avoid background noise, all participants will be muted for the duration of the webinar. We will be addressing questions at the end of the webinar. If you have any questions while the webinar continues, please enter them into the questions box, which is located on the right-hand side of your screen if you're viewing from a computer, or at the bottom of your screen if you're viewing from a phone. We will be reviewing questions as they come in, and if we see something in particular that is unclear or needs to be expanded, we will ask Dr. Dan Hale to do so when the question is asked. If you have any comments or concerns during the webinar, please also enter those into the question box, and we will review and address any immediate needs as they occur. A recording of this webinar will be emailed to each registrant tomorrow. The recording will also be available on our website at www.namimd.org for any individuals that were unable to register. Continuing education units are not available for today's webinar. However, a certificate of attendance will be sent to each registered participant tomorrow afternoon. After the webinar today, you will also be asked to complete a short survey on the aspects of the webinar that you felt were helpful, could be improved, and what you thought you would like to see in future webinars. Each person that completes the survey will be entered into a drawing to win a $25 Amazon gift card. And this is the only webinar in a series of educational webinars that NAMI Maryland plans to host. We ask that you please fill out the survey to let us know how NAMI Maryland can best support you during this time.
I'd like now to welcome our speaker for today's webinar, Dr. Dan Hale. Dr. Dan Hale is Special Advisor to the President of Johns Hopkins Bayview Medical Center and Director of the Healthy Community Partnership. He is also an Assistant Professor at the Johns Hopkins University School of Medicine, with appointments in the Department of Psychiatry and Behavioral Sciences and the Division of Geriatric Medicine and Gerontology. Prior to assuming his position at Johns Hopkins Bayview in 2011, Dr. Hale was a professor of clinical psychology at Stetson University. He is the author of several books, including Depression, Out of the Darkness, and Into the Light. In 2016, He was named Mental Health Professional of the Year by NAMI Metropolitan Baltimore. And in 2018, he received the Maryland Foundation for Psychiatry Anti-Stigma Advocacy Prize. Thank you, Dr. Dan Hale, for joining us today.
Thank you, Mackenzie. It's very good to be with you today. You can see the title I chose, Depression Out of the Darkness and Into the Light. To me, it has two meanings. One is that, unfortunately, we don't talk about depression enough. We know it's there for us, maybe, or certainly for others, but we keep it in the dark. And I think we need to bring it out into the light and talk about it more. And then depression itself is often experienced as darkness, just sort of being totally enveloped by darkness. And yet we know this is a treatable condition and that you can emerge out of that darkness, out of that depression, and into the light. So what I want to do is start by just talking about the impact of depression. We can come back to this if you have some particular questions later. One, we know that this depression, and I'm going to be talking about what we refer to as a clinical depression or a major depression, which is different from the sort of normal sadness we all experience as when we have disappointments and losses. So this depression can seriously damage relationships. It can sidetrack and even end careers. We know that it can also aggravate or complicate other medical illnesses, especially those where you have responsibility for monitoring your condition like diabetes and managing it. And depression can make that far more difficult. And then we know that this is the major risk factor for suicide. And I'm not going to be giving you many statistics today, but I'll put this one in there. More than 48,000 Americans die each year by suicide. You can compare that to the number that die by homicide, which is around 19 or 20,000, motor vehicles, around 30,000 or so. And we know that that 48,000 is an undercount because many of the deaths that are listed as accidental in terms if they involve drugs, they'll be listed as accidental or undetermined. And if you go in more deeply, you find that often many of those are suicide. And then, of course, it is a major risk factor for substance use. How many experience this in a typical year? And of course, we're not in a typical year. More than about 10% of American adults experience an episode of this major depression. More than 20% will experience at least one episode at some point in their life. So this is a highly prevalent, common condition. How is it in this year? Well, the CDC, Centers for Disease Control and Prevention, runs a survey every few weeks. And one that was conducted in October found that 26% of American adults reported symptoms of major depression, and 32% reported symptoms of generalized anxiety disorder. So we know that the rates are much higher right now. We also can look to the crisis lines that are experiencing overwhelming increase in the number of calls, often 10, 20 times as many calls as they had in 2019. So clearly it is contributing to a major health problem right now. I'm going to speak from both my professional and personal experience. Just to give you, I'll go over that briefly. So in 1972, I began my graduate training. And of all the mental health conditions that were sort of available to focus on, I found myself drawn to depression. Now, it wasn't because I had ever experienced depression before, or as far as I knew, no one in my family had ever experienced it. But what intrigued me and got me working on, there were two or three things. One is to look at individuals who clearly were successful, loved, respected, accomplished. And this condition called depression transformed them into someone who no longer felt worthy of living, no longer wanted to live, no longer felt loved, no longer felt respected. And how could this condition change someone so much? That really, I wanted to understand it more. A second aspect of it was that when I realized just how serious it was, as I just covered, this is a disease that can literally kill people. And so I wanted to be involved in some meaningful work. And the third part of depression that really kept me hooked on it was when I realized that it is a treatable condition. And as a psychologist, as a psychotherapist, I could play a role helping people recover. And that's tremendously gratifying to be able to help someone who may have been right at the brink of death to be able to come back and recover everything that they had lost with that depression and to enjoy life again. So I began my practice 4 years later and continued to focus on depression. And I felt very good about what I was doing, and I thought I understood depression very well, and I think I had a pretty good understanding. But in 1988, so 12 years into my practice, I had my first episode of depression. It came during a very stressful period of my life. So in one sense, it wasn't totally surprising, but I had never experienced this deep, deep, dark depression before. I'd heard about it with my patients, but this was new to me. So all my training didn't protect me from it, but it did guide my reaction. I knew that I needed to get some medication. I knew that I needed the help of another psychologist. And with those two things, I was able to recover and come back and function really 100% again and enjoy life immensely. In fact, in 2005, looking at that, 17 years later, I was really enjoying life. There weren't any major stresses in my life, but depression came again. It was just as severe, perhaps even more severe than that first episode. It didn't seem again to be related to anything going on. It seemed to have been somehow internally triggered. And I think that's important to note. A couple things there if I look at these two episodes. One is that often you have more than one episode of depression. We talk about it being a chronic condition with episodes. And so if you have one episode, there's a good chance you're going to have a second one. And it also illustrates that it's not always the same cause. There are different ways that one can end up depressed. Sometimes it seems to be a part of experience. Sometimes it seems to be unknown what has triggered it. And then, as you can see there, a number of years later, my daughter, who was 36 years old at the time, died by suicide. She had struggled with depression during her teenage years, which isn't unusual. It's a period of life when it often hits. She had been treated, recovered, but continued on and off to experience episodes. And in 2012, experienced a very serious episode, made the attempt, and although spent a number of months in the hospital, eventually died in early 2013, which just increased my commitment to doing whatever I can to help others understand and treat this condition. So there are a number of challenges we face when we're trying to help people with depression. One is that often people don't recognize the symptoms. I mean, they know they're feeling bad, they're not feeling good, they're hurting in some way, but they don't realize that this might actually be a clinical syndrome, a cluster of symptoms that says this is really an illness. And so people need to understand what the symptoms look like. A second challenge, so even if we get people over that hurdle, you might say, another thing is this terrible, unfortunate thing we have called stigma, and it's still there. People may be embarrassed or even ashamed by the fact that they have a mental health condition, and so they don't acknowledge it to others. They don't seek the care. So I hope that we can do things to overcome that stigma. A third aspect of it that often keeps people from seeking that treatment is a sense of pessimism, which is really part of the depression. You know, when you're depressed, you feel like nothing is going to be ever helpful to you. Or there could be misconceptions about treatment. The treatment is always very lengthy, several times a week for years and years. And that's not the typical approach to treatment for depression. We'll talk about treatment a little bit later. And the fourth is that, unfortunately, even if you get over those first three hurdles, sometimes people can have difficulty finding affordable professional care. So what I'd like to do is go over the symptoms, and I will on some of them, to sort of illustrate from my own experience. The first is a depressed mood with overwhelming feelings of sadness and feeling empty, or perhaps feeling numb. This is much more intense. Like I said, Early in life, I had experienced disappointment, sadness, been discouraged at times, but this was different. It was most similar to grief, but with grief, grief tends to sort of come in waves. So even as I dealt with losses in my life, my parents, and grieving over them, I didn't grieve every single minute of the day because I could still think about the good times and how fortunate I was to have had them as parents. With depression, the mood was always down. There was never any relief, never any reprieve. It was with me every moment of every day. And that's quite typical of it for others too. The second, and I think this is a very important symptom to be aware of, because a depressed person many times has lost the ability to enjoy things that they previously enjoyed. And those can be social activities, getting together with friends. Those could be physical activities, playing sports. Those could be solitary activities, just reading or listening to music or watching movies or shows or whatever. And when you become depressed, you often lose that ability. You might even be watching something that's interesting or funny, but it can't really grab you the way it did before. And the reason I like to focus on this symptom in particular is because this is a symptom that might be one of the first to notice, because a person is no longer going to those social activities they did before. Or if they're there, they're no longer showing the enthusiasm. So sometimes that's the first thing you might notice. A third symptom is a significant change in weight or appetite. And this can really go either way. Now, people will often say, when I'm depressed, I eat more, and that is true for some. But often when somebody is seriously depressed, they've lost their appetite. Nothing tastes good, nothing sounds good. They don't have the energy to fix good, healthy meals. They don't feel like going out to get a good meal. So it's not unusual to actually experience a loss of weight. And so I know I used to work on a college campus. When I would notice a student having lost some weight, I would always sort of inquire, have you lost some weight? Is that something you were trying to do? Sometimes they weren't trying to do it. They were experiencing depression. A fourth symptom is a significant change in sleep patterns. And this can also go either way. So, some people, will say, when I get depressed, I sleep more. And that may be true. Sometimes what they're talking about is they're actually spending more time in bed trying to sleep because they don't feel very good, but they're not really getting good quality sleep. But often for a serious depression, it could be that they have more trouble sleeping. And that can occur either at the front end of the sleep cycle or at the back end. So in other words, you may find that, and I'll use my own situation as an example. Before I became depressed, I used to be able to fall asleep very easily. When I was depressed, I would lie awake 60, 75, 90 minutes longer than I ever had before, unable to get to sleep, often because terrible thoughts were going through my head. I'm such a terrible person, the future's so bleak. I'd finally fall asleep exhausted, but then wake up about 4:30 in the morning rather than 6:30 or 7. Not rested, not ready to get up and take on the world, but unable to go back to sleep. It's a very discouraging time to sort of sit there or lie there in the dark. A fifth symptom is this fatigue or loss of energy. So tasks that you used to be able to do effortlessly, whether it's just little household items, washing the dishes or, cleaning up the room or grocery shopping, anything like that, now tires you out. You just can't, they seem overwhelming, and you just can't find the energy to do things that you used to do. Some would describe it even as a weakness, uncertain that you have the strength, not only the energy, but the strength to just go out of the house and take on anything. Another symptom is being physically slowed down or perhaps restless. So let me start with the first part there. Often the person just moves more slowly, they talk more slowly, and just can't seem to be as effective or as efficient as they were. But they also may experience anxiety, agitation, restlessness. So at points they may not be able to sit down at all or to stay still. It's such an uncomfortable state to be in. And so they may end up pacing the room rather than sitting down or resting. It can also affect your thinking and your concentrating and your ability to make decisions. Your problem-solving skills seem to diminish. If somebody is talking to you, it may be difficult to stay focused on the words that they're saying, because you may have caught their first sentence or two, and then your mind goes off someplace else. So when that happens, what may appear then is you have a memory problem because you didn't hear what they told you. So when later they say, remember when I said something to you, and you go, I don't remember that. And it can be also, facing decisions. They all just seem too big. And so an important aspect of this is that if you're an older adult, if you're 65, 70 years of age, and you begin to have memory problems, we often jump to the conclusion this person must have Alzheimer's or they're going down that road of dementia, when in fact, it could be depression. And the importance there is for depression, we have good treatments. And then there are these feelings of worthlessness. I started by talking about, when I began my work in psychology, and I was talking to these people who clearly were loved, respected, successful, and they were telling me with absolute conviction, they felt worthless. They felt that they did not deserve anything that had ever happened to them. They often felt like an imposter, a fraud. They had fooled people because other people thought they were a good person, a smart person, and they didn't understand that really they were a very bad person. Or they felt guilty about things that they had no reason to feel guilty about. And they felt hopeless about their situation. And the last symptom is frequent thoughts of death or suicide. And the thoughts of death don't have to be about suicide. And it could be sometimes people just wishing that death would come earlier rather than later. I had a good friend who was depressed. And one day in another city, I maintained my contact with him by phone. And he called me one day and said, a colleague of his had just been diagnosed with a terminal illness. And he said, my thought was, why couldn't that have been me? He said, Dan, I'll never kill myself. But, if I were to develop a terminal illness, that would be a relief. So these thoughts just sort of were always there, or there most of the time. Now, I've gone over 9 symptoms. And I started off by saying there's something called major depressive disorder or clinical depression. So how would that be diagnosed? If you look at those 9 symptoms, if someone were to have 5 or more of those symptoms experienced every day or almost every day during a 2-week period, and at least one of the symptoms was that first one I listed, depressed mood, or the second one I listed, loss of interest or pleasure in activities previously enjoyed. So if you met those criteria and it was clearly a change from how you had been, and clearly it was impacting your life, your social relationships, your work, so forth, then you could be diagnosed as having major depressive disorder, which would, we believe, often merit treatment. We can talk about treatment in just a minute. Now, there are 2 other conditions where you might be seeing depression. And I imagine everyone has heard of bipolar disorder. Some still refer to it as manic depressive disorder, and that's fine. And so with bipolar disorder, and there are 2 types, with bipolar 1, the person experiences a period of mania. And that is an excessive, extreme, and dangerous state of enthusiasm, euphoria, and that's bipolar 1. I'll elaborate later if people have questions. Or there's something called bipolar 2, where the person doesn't go quite into that full manic state, but still they're hypomanic. Hypo means below mania. So it's somewhere between normal mood elevation and the manic episode. But they also experience depression. And both of these are severe conditions because that going up and down takes a tremendous emotional toll on you. And then there's another one that still merits attention. It's not as severe. It's called persistent depressive disorder. Used to be referred to as dysthymia, often still is. And this is a milder but chronic pattern of depression. So the symptoms aren't as extreme, but they're there with you almost every day, more days than not, for at least 2 years. So a person is generally functional, but they never feel very good. They're always down in the dumps. And again, this is a treatable condition. So this issue of, making sure you understand what the symptoms might be for these various conditions is important. Now, sometimes I'm asked, what's the difference between depression and stress? And I think that's a particularly relevant question during this year, during the pandemic, because many of the symptoms are the same. I mean, I imagine many of us, even if we aren't feeling depressed, still are feeling more tired, more stressed out. Our sleep isn't as good. Perhaps even our appetite has been affected. So is that depression? Is that clinical depression? And I think there are 2 or 3 symptoms that I look for that sort of says this is more than stress, that in fact this really might be crossing over into depression. So one of those is that symptom of, being able to enjoy things. Even during the most stressful times when I might be working 12, 13-hour days, I still can say to myself, I can't wait to get to the weekend because then I'm going to do something positive. So, but when a depressed person probably can't even think of something that appeals to them. A second symptom is a sense of hopelessness. I think especially with the news we've had in the last couple of days on vaccines, we've realized that the pandemic will end at some point. But if you're depressed, you may not be able to see anything hopeful in the future. There is no light at the end of the tunnel. And the third thing you look for that would say it's more than stress is this very harsh self-judgment where a person is feeling, I'm a bad person now. So it's gone from, this is a terrible situation out there I'm dealing with to I'm part of the problem. I'm just stupid. No one's ever going to love me. So when you see that hopelessness, that harsh self-assessment, and the inability to enjoy things, then I'm thinking there's a good chance this is depression. Causes. There is no one cause to depression. I mentioned before, I was going through this terrible period in my life, several losses, and I would say that stress led to that. But then a number of years later, it seemed to come out of the blue. And there are probably a number of different contributing factors. But whatever the contributing factors, we can say with confidence, with optimism, there are good treatments available, both psychological and medical treatments. So let me just take a few minutes to talk about treatments. Where does one go if they believe they might be seriously depressed? So we talk about seeking out mental health professionals. Let me just run through those basic categories here. First are psychiatrists. So psychiatrists are trained as physicians, usually have gone the pre-med route and then 4 years of medical school and then 4 years of internship and residency. Many of them, though, do not do psychotherapy anymore. They may have a strictly medical practice. We'll talk about medications in a minute. Psychologists, and that's my training, are doctoral level professionals, either doctor of philosophy and psychology or doctor of psychology, generally about 5 or 6 years of training before they begin their practice. They are skilled typically in both assessment, diagnostic work, and also in treatment, psychotherapy. And then there are clinical social workers who have a master's, at least a master's degree in social work and ample clinical training. There are also mental health counselors, generally have 2 or 3 years of training and certainly plenty of supervised experience, clinical experience. And then there are psychiatric nurse practitioners, some of whom do psychotherapy and some of whom may emphasize more medications. So there are two, I listed here, 2 well-established therapies. One you hear a fair amount about, CBT, or cognitive behavioral therapy, and then the other is interpersonal therapy. So for both of these, I think it's important to correct any myths or misconceptions, because some people still assume that psychotherapy means you're going to just, sit there or lie there in the therapist's office. You're going to be delving deep into your childhood experiences, how you felt about your mother, how you felt about your father, any early traumatic experiences, and that this is going to take a long time. Or others assume that all therapy is about is simply venting, simply releasing all of your negative emotions. Actually, the therapies for depression tend to be much more focused. They tend to, although they do not ignore the past, they tend to focus much more on the present. They are they're about much more than just simply complaining or talking about symptoms or feelings. They tend to be very focused on cognitive behavioral therapy, particularly on the thought processes. What is a person thinking? Because often these negative thoughts are leading to dysfunctional, unhealthy behaviors, which in turn just lower the mood more and more. You often see this sort of downward spiral where the person's thinking negatively about themselves, about their world, about the future. That changes their behavior, so they become less active. They no longer are around people that generally can be reinforcing to them, and their mood continues to go down. And so the therapy focuses on identifying and then modifying those dysfunctional thoughts, those unhealthy thoughts, those dysfunctional, unhealthy behaviors, and the mood tends to follow those. Interpersonal therapy is also fairly short term. Both of these fairly short term. When I say that, 5, 6 sessions, maybe up to 15 or 20 sessions. But it's particularly if the depression seems to be related to new social roles. So you've gone through a divorce, you've experienced loss of a loved one, you've got new relationship challenges, you have troubles with relationships. And again, this tends to be fairly practical, fairly present focused. And both of these have very good results. Now, I mentioned psychiatrists. Let me talk about not only psychiatrists, but other physicians as well in terms of treating medically. Actually, most antidepressant medications are prescribed by primary care providers. I think that's important because if you say, where do I start if I think I might be depressed and my mood is so low and I'm having trouble sleeping and I've lost my appetite and I think I might need something to help my mood, a good place to start is with your primary care provider. Most are trained to assess, and many feel comfortable prescribing antidepressant medications. Usually they're comfortable, have 3 or 4 that they would feel comfortable trying out. If they don't feel comfortable with the antidepressant medications, or if the ones they try out don't seem to have good effect, then they would probably refer you on to a specialist, a psychiatrist. You could always start with a psychiatrist, but the number of psychiatrists in most communities is fairly limited, so you might have difficulty. So starting with your primary care doc is a good place to go. Now, antidepressant medications, the most popular ones today are SSRIs. That's selective serotonin reuptake inhibitors. We don't have to go into depth on these, but I put up this slide to just sort of illustrate the way that our neurons communicate with each other is actually through neurotransmitters, through chemicals. And so when a message, you could say, gets to the end of one neuron, the way that message gets to the next neuron is these chemicals spill out into the space there, this little space called the synapse. These medications keep that chemical, those neurotransmitters in that synapse longer. So it enhances, it strengthens communication. So serotonin is one of those neurotransmitters. You'll also hear about norepinephrine. So there are serotonin and norepinephrine reuptake inhibitors. Both work in the same way. Also, some drugs that affect dopamine. Now, an important thing to understand about antidepressant medication is it does not work instantly. Unlike some of the anti-anxiety medication, if you were to take Xanax or Ativan, where you get a pretty quick response in terms of calming you down. These antidepressant drugs could take 4, 5, 6 weeks before you have the full effect there. And so it's important to know because you don't want to give up too soon. And if it's a loved one that you're trying to help out, you want to encourage them to stay with the medication. If the medication isn't working after several weeks, or if you're having a couple of side effects, please go back to your doctor, share that information. You need to stay in touch with them, but don't give up without talking to your doctor about these. Now, I want to, I've done talks about depression for a long time, and often the people that have come to a workshop are there more to find out what they can do for a loved one. And I think that's very important to understand how depression affects family and close friends, because the person has really changed in ways that can be very frustrating for you. If it's a spouse, a partner, a loved one, and you enjoy doing things with them, and you received warmth and love and affection from them, and those things are gone, that is so frustrating, And it's not only frustrating, it can be very hurtful, because you may be doing the very best you can to help them. And they look at you and say, there's nothing worthwhile in my life. That's a hurtful statement. Or they can't offer the affection, the intimacy that they were able to offer before. And so the temptation, how you feel, is you want to say, snap out of it, because you're saying, I want you back. But that's not the way to go. That does not help to, say snap out of this or just get over it or just deal with it. That's not going to help someone who's already depressed at all. What does help them? We did some surveys and interviews, and what people talked about in terms of helping them get through that depression, and not only was the treatment, but the people, they listened to me. They took time for me. They took the initiative to check in with me. And I think that's an important one. I know if I hear somebody's having a problem, medical problem or typical physical problem, I might say, let me know if there's anything I can do for you. With a depressed individual, most of the time they won't take you up on that offer. And so the fact that you're proactive, that you reach out and say, I'm gonna check in with you every day or two. When they say you don't need to, I say, well, I know I don't need to, but I want to. I'm concerned about you. I love you. These are the things to offer them that reassurance. Depression can certainly lead to a crisis. Even if you are not suicidal, or the person's not suicidal, there are still some lifelines out there that you can reach out to. There is this National Suicide Prevention Lifeline, staffed 24/7. They will connect you with a professional person that can help you with the crisis. Like I said, even if the person's not suicidal, but you don't know what to do because they're just so distressed, or you're so distressed, you can use this. If you're more comfortable texting, you can use that number and you just text talk or help, and you'll get a response. Again, 24/7. Now, I want to make sure I'm almost done with my presentation because I want to have some time for questions. But sometimes people want to know more. If you don't feel like you've really understood what it's like to be depressed and you want to know because you want to help someone, this wonderful little book, only 85 pages, called Darkness Visible, A Memoir of Madness by William Styron, a great writer of novels, and he is able to capture what it was like for him. This was by Willow Wheat for Me, A Black Woman's Journey Through Depression. again, another sort of first-person account of what it was like. In terms of bipolar disorder, Kay Redfield Jamison is a psychologist, actually on the faculty here at Johns Hopkins, who is one of the best known experts on bipolar disorder, partly because she went through it herself. And is still says she has bipolar disorder, but it's under control. Again, a great account of what it's like to live with this condition, or to live with someone who has this condition. This was mentioned earlier. I've done a little book that sort of talks about my personal experience, my professionals, and what it's like to have a daughter who struggled with this. So these are some of the topics that I cover. And so there are many good organizations at the top of my list, and it's the top of my list wherever I show this is the National Alliance on Mental Illness. We have local chapters, state chapters, and national organizations. And these are some other organizations there: Mental Health America, Depression Bipolar Support Alliance, which often has support groups available to you, good information on depression from the NIMH or American Psychological Association or American Psychiatric Association. So I think that takes me through that. And if am I back? Mackenzie?
All right, thank you so much, Dr. Dan Hale, for providing that critical information during this time of need. Right now, we would like to do a Q&A, and we will open up the chat for the questions, if any questions that you might have. All of the participants will stay muted to avoid background noise. And you can type your question into the question box on the right-hand side of the screen if viewing from a computer, or at the bottom of the screen if viewing from a phone. If you have a question that you'd like to ask, or if you have a comment about the webinar today, please enter that into the question box at this time. So we do have a couple of questions. I'm going to pull a couple of them for the remainder of the webinar. One of the questions that we received was, how do you recommend dealing with depression in young students that are going through the transitional period of going into virtual learning environment when they're so used to being in person and learning instead?
Yeah, I mean, the pandemic has disrupted routines for so many of us. And certainly for students, it's greater than ever. Routines, I mentioned routines because routines actually tend to sort of help us get through life on an everyday basis. And now that's often been taken away from them. And then you look at what's happened in terms of the social contacts. And with many students, that's the main attraction of going to school. Yes, learning is great, and certainly is, but it's also a good place to meet people and socialize. And there are activities that are related to that. A grandson that played baseball is not playing baseball right now. And after-school activities. So we need to recognize that, how has their routine been disrupted? How can you build a new routine as much as possible? And so that's in terms of getting up, and that's in terms of eating and making sure that they're eating well. But also that they are staying in touch, not just for the academics, but the social part, whether that's Zoom parties or so forth. So I think those are the sort of positive things you try to make sure you build in. But then you need to be listening to them. And you need to be checking in. You as a parent need to be checking in regularly to sort of say, how are things going? And to be able to listen without judgment, without criticism, to try and empathize, because their life has really been changed. And I think another thing is that, for those of us who have lived as long as I have, there's a sense of perspective here. Even during the 2 months ago, when there was no, definite sign about a vaccine yet, there was still a sense of, this is a crisis, but we get through a crisis. One way or another, we're going to get through this. If you're 13 years old or 17 years old, you've never faced something like this before. And it's easy to feel very much overwhelmed. And you need to also be very careful or alert to, what information do they have about the pandemic? There's a lot of misinformation out there that would be very discouraging and depressing and alarming. So you want to make sure that you have and they have accurate information. As we know now, we've now got 2 vaccines that seem to, early results indicate that they're 90–95% effective. That distribution hopefully will be started in December, and by spring, most people will be able to re-engage in life as they have enjoyed it before. So I think to, again, listen carefully, know what to be looking for, and to be offering that perspective.
Okay, thank you for that answer. We have another question in regards to medication. So it's kind of a combination question where the participant asked the fact that they start to feel that they're kind of getting used to their medication, and if that means that they're going to be dependent on that medication for depression for the rest of their life, or they would eventually come off of that medication.
Oh, that's a great question. I mean, it gives me some opportunities to cover some things I probably should have done myself with my presentation. So I mentioned that antidepressant medication takes time to take effect. It could take 4, 5, 6 weeks before you get that full beneficial effect. What we know is that once all of your symptoms have gone, so now you're sleeping great again, your appetite's back, you enjoy life, you're going through normal activities, you should stay on that medication at least 6, if not 12 months. I say that because it reduces the risk of another episode. And so the idea, some people feel like their measure of success is how fast can I get off my medication? And that really shouldn't be your goal. Your goal is how can you sort of get back to enjoying life 90, 95, 100%. And once you're there, to stay on it so you can reduce the risk. If you have a second episode down the road, for me, you saw, it was a number of years later, then that raises the question of, do you want to consider staying on it indefinitely? And to be transparent, that is the decision I made for myself. So I am 15 years past my last depressive episode, but just as I take my cholesterol medication every night, I take an antidepressant every night. So I certainly, that's something you would do in conversation with your provider. But it's a great question, because there's certainly you want to stay on it for a long time.
Okay. Since you mentioned that you do take an antidepressant, one of the questions was in regards to which medication it was that helped you with your depression. So
I actually want to know which medication?
Yeah, that was one of the questions.
Yeah, and that's fine. Let me answer that a little. So the first time I was depressed, the medication that I was prescribed is what we used to sort of a first generation antidepressant. It worked okay, but it also had some unpleasant side effects that I could handle. With my second episode, the doctor tried, my family doctor tried a new SSRI. It did not help me. In fact, it brought on anxiety. Tried a second one, it also brought on anxiety. So at that point, I was referred to a psychiatrist who I think carefully assessed where I was and what might help. And the medication I went on, the brand name is Remeron, the generic is mirtazapine. One of the, each of these medications has at least some little bit of side effect. One of these is the side effect of mirtazapine, Remeron, is it's sedating, which means I get a good night's sleep every night, which is worth a lot. When I know that I can, as long as I get a good night's sleep, I feel pretty confident about handling the next day. But there are a number of good ones. I mean, they're just, we are blessed with a number of good antidepressant medications.
Okay, thank you for that. Another question that we have is, what should comprehensive community care systems look like so that we can better screen and treat for mental illness? What are some examples of cities or regions who you think are doing this well?
Oh, I wish I had a good example of cities that are doing this or regions that are doing this well. I think depression has, mental health services have not gotten the attention that they've deserved, that it's needed. I think that one of the things that we're trying to do is to make sure that when you go in to see your primary care provider, that you are completely assessed with a couple of good questions to see whether or not you might be depressed. Ideally, and some are doing this, is to have the behavioral therapist, it's often the term that's used, psychotherapist or behavioral therapist, right there in the clinic, so that when your doctor says, you know, you've gone in because you're having trouble sleeping and you've lost your appetite and so forth, and she or he, you know, asks a few key questions and says, you know, I think, you know, it might be depression. And it would be really good if I could not only prescribe medication, but if I could link you up with a therapist. Let me walk you down the hall and introduce you to so-and-so. That warm handoff is what really helps. So there are systems that are doing that. I think we're trying to move more toward integrated systems. That would be one way. I think what I need to call out here and to compliment is, and I believe Maryland is the only state where this has been put together. There is a organization called the Pro Bono Counseling Project, where about 800 therapists in the state of Maryland have pledged to take on at least one non-paying patient. And so this organization, you know, you can get their number, Pro Bono Counseling Project, and they can assess, you know, if therapy does seem right for you and help link you up in case that you don't have insurance or can't afford that. So that's a sort of like I said, just sort of talked by them last week, and you know, in terms of a statewide effort, Maryland's the only one with that.
Okay, thank you for that. We have had a couple of questions about TMS therapy, which is transcranial magnetic stimulation, I believe, if I'm not wrong, and just what your thoughts are about that kind of type of therapy in regards to depression.
Good. So I'm gonna answer about two things. I haven't been asked, but before I get to TMS, so some depressions are resistant to the initial treatment. And so we talk about treatment-resistant depression. One approach that is has been found to be very effective with treatment-resistant depression is electroconvulsive therapy, or ECT. I wasn't asked about it, but I bring this up because it is one, if you saw the movie One Flew Over the Cuckoo's Nest, which is a great film, won the Academy Award, but that is not how ECT looks today. So ECT, which is done inpatient hospital, there is no convulsion, there's a very mild seizure, but it's very effective. So that's still there, and I think if I were to go through a third depressive episode and medication and therapy didn't work, I would consider going for ECT. I just want to put that out there. But another one that is sort of in the early stages is transcranial magnetic stimulation, TMS, repetitive transcranial magnetic stimulation. I've observed it, haven't had it myself. It's very non-threatening. You sit in a little room and you put on a cap first and then a helmet. And then that, so there's nothing that goes into your skull or nothing invasive. And for about 20 minutes, you're going to be, these powerful magnets will come on and off. And they seem to do a good job of increasing that neurostimulation. It's not painful. You can sit there with your one person, you know, play the game on his phone, another read a book. So it's an encouraging development that is still in the early stages in terms of, but it is offered at Johns Hopkins.
Okay, thank you for that. I think we have time for about one question, and a lot of other questions that we have received are, how do you handle depression with like another mental illness in conjunction with it, such as bipolar disorder or ADD, and how you would really tackle the depression of a person that already exhibits symptoms of bipolar or personality.
Yeah, so it's a good question for which I don't have an easy 60-second answer to it, but it raises the issue that often depression is not simply by itself. I talked about how it could be there with bipolar 1 or bipolar 2 disorder. Those are a little trickier to manage. So I generally would recommend trying to get in to see a psychiatrist, at least for some consultation on that. Anxiety is often a part of depression. Anxiety can make treatment a little more difficult. But the antidepressant drugs also tend to work pretty well on the anxiety itself. So when we talk about the anti-anxiety drugs I mentioned earlier, you generally don't want to be on those for a long time. But in terms of for long term, often, even if it's the anxiety is the only problem, the antidepressant medication be used. And then I would just say, you need to find the mental health professional most skillful around whether it's ADHD or a personality disorder. There are treatments, but I would definitely want to be working with an experienced, skilled therapist. And organizations like NAMI may be able to help you locate that. I would also encourage you to reach out to family and support groups, because often the best advice you can get is from others who have gone or are going through similar experiences.
Okay, thank you for all of those questions that you were able to answer. And now I'm going to hand it over to Mackenzie for our closing remarks.
Thank you so much, Dan and Maria. So unfortunately, we do have many questions that did come through, but we only have time for an hour today. Just to let everyone know, this is only one webinar in a series of webinars. So Dr. Dan Hale will be joining us again. We have 3 webinars upcoming each month. One will be on the topic of lived experience, one will be on treatment, and then the other one will be on beyond treatment options. So please do join us. And if you have any questions, please don't hesitate to reach out to us as well. We'd be happy to answer those. So thank you everyone for joining us. This webinar has been recorded and it will be emailed to all registrants tomorrow. We will also be posting this on our website at www.namimd.org for anyone who wasn't able to register today. We hope that this webinar has been helpful for you this afternoon. At the end of the webinar today, you will be asked to complete a short survey on the aspects of this webinar that you felt were helpful, could be improved, and what you would like to see in our future webinars. Each person that completes the survey will be entered into a drawing to win a $25 Amazon gift card. This is only one webinar in our series, so please do join us for our next one and let us know in the survey how we could improve so we can better our webinars in the future. Our next webinar will be entitled Finding Your Way Through the Dark, Living with Depression, and it will take place on Monday, December 14th at 12 o'clock. I will include the registration information in the chat in a few moments, and anyone who would like to join us can certainly register today. We wish you all a safe and happy rest of your week, and please don't hesitate to reach out to us should you have any questions. Our phone number is 410-884-8691, and our email is info@namimd.org. Thank you so much. Kate, do you have a few words you'd like to share?
Well, actually, I hadn't planned on it, but I just have to say that every time I hear Dan speak, I always learn a little something new. But I'm especially excited that we were able to turn this into a series with a variety of perspectives and information. So thank you very much, Dan and staff and everybody who listened in. And I look forward to more and more of these. Thanks again.
Thank you. Enjoy.
Thank you.